Good afternoon, everyone. It's our virtual interdisciplinary conference on abdominal radiology. Before anything else, let me call on a member of the PSG Committee on Training Program who will make sure that the fellows will maintain a high level of training in hepatology, and my batchmate from UST Medicine, Dr. Suzette Coherman, to lead us to prayer. Dr. Herman.
Thank you, Ome, for that kind introduction. Okay, so let us put ourselves in the presence of our Lord. Dear God, we are gathered here today for our virtual interdisciplinary conference on GI radiology. Please send us your Holy Spirit to be our guide and give us wisdom to understand the topics we are going to discuss today. Enlighten our minds and let your love be upon us. May this conference be fruitful and may it bring us one step closer to becoming even more greater physicians for our patients. All this we pray through Christ our Lord. Amen. Thank you. Amen.
Thank you very much, Susie.
Welcome.
Right. So again, thank you for joining us. It's been 3 weeks and we have generally very good reception and feedback from everyone who has been attending our conferences, and we look forward to more meaningful conferences in the next few weeks. So just a recap, can we have the right. So before I give you the I would like to today that we have been discussing abdominal radiology. We have been discussing in the past the pancreaticobiliary system. We also did a week on the small and large bowel, followed by the liver and biliary tree. And finally, we are now in the radiology of the esophagus and the stomach. So a little reminder for the house rules of this afternoon's conference. So this is again brought to you by the PSG Committee on Training on you will be on mute while you are inside the meeting room or our conference, and it's going to be very helpful for both the participants and the discussants to use two-way earphones or headsets with microphones for clear audio input and to reduce unavoidable audio interference from your location. And this webinar is going to be delivered to you via Zoom, and it's going to be in the format of a PowerPoint presentation being shared by a third-party host who will be controlling it upon prompting. And we encourage everyone to participate in the discussion by typing in your questions in the Q&A panel and not on the chat box, even while the panelists are discussing, and we will be discussing your questions during the open forum after both the lectures this afternoon have completed. Okay, so again, this is the fourth Saturday. So can we, okay, so for the, while this is the last Saturday that we will be discussing GI radiology, we're still not yet done. For next Saturday and the following Saturday, we will be discussing GI pathology. So for this coming Saturday, July 25, the topic will be the esophagus, the stomach, and small and large bowel, which will be discussed by Dr. Glenda Pua and moderated by Professor Jose Soliano. And for August 1, the liver and pancreas pathology will be discussed by Dr. Marife Bonifacio. and moderated by Dr. Jade Hamias. Okay, so for this afternoon, we have two lecturers who will be discussing both the normal and the pathologic radiology of the esophagus and the stomach. But before we proceed, I would like the participants also for taking the time, joining us and making us part of your regular Saturday afternoon. And speaking of schedules, I can't imagine someone else with a busier calendar the past few weeks in the name of service, the indefatigable president of the Philippine Society of Gastroenterology, Dr. Jose Galang, to give us the welcome remarks. Dr. Galang.
Thank you very much, Dr. Romel Romano. Good afternoon and welcome to our virtual interdisciplinary conference. We would like to thank the Philippine Society of Abdominal Radiology for this collaboration with the Philippine Society of Gastroenterology in order for us to augment and supplement the cognitive learning of our training fellows that have been affected by the present COVID pandemic. This is also a good time for us to revisit important concepts in radiology, particularly to all the members of the PSG. And I just would like to give a side note to all our training fellows and all our recent graduates that I would like to announce that the Philippine Specialty Board of Gastroenterology has earmarked or has set the date for the written examinations on November 8, 2020, and the oral examinations on November 29, 2020. Without further ado, I would like to give back the mic to our host, Dr. Romel Romano. And again, thank you in advance to our speakers who will be introduced formally later on. And we have our moderator, a past president of the Philippine Society of Gastroenterology, as well as the Philippine Society of Digestive Endoscopy. Thank you and good afternoon. Happy learning.
Thank you very much, Dr. Taxing, for you to join us every Saturday, but thank you very much. All right, so for the next part, I would like to and privileged to introduce our moderator for this afternoon. He's one of the reasons that I became a gastroenterologist. He was the chief of section of gastroenterology at the UST hospital when I was a fellow. He's also a pioneer in the training of ERCP in the country. He is a professor in the UST Faculty of Medicine and Surgery, a past president of the Philippine Society of Gastroenterology and Philippine Society of Digestive Endoscopy, the 2019 PSG Presidential Awardee, a GI Maestro, and someone I hold in a very high regard, Dr. Albert Ismael. Dr. Ismael.
Thank you, thank you, Dr. Romano. Thank you, Dr. Romano. The first speaker for our radiology topic this afternoon is Dr. Mark Joseph Sibal. He is a graduate of University of Santo Tomas, cum laude. He was a resident physician at the NKTI in imaging and therapeutic radiology. And I believe he is still a consultant now at the NKTI. So to tell us more about imaging of the esophagus, may I present to you Dr. Mark Joseph Sibal.
Thank you very much for the introduction, Dr. Ismael. I'd like to thank the Philippine Society of Gastroenterology and the Philippine Society of Abdominal Radiology for the opportunity to share some insights regarding the imaging of the esophagus. I'd also like to acknowledge the Department of Medical Imaging and Therapeutic Radiology of the National Kidney and Transplant Institute for allowing us to use some of their cases in today's discussion. This afternoon, these are my objectives: to quickly review the anatomy of the esophagus and its surrounding structures and translate this knowledge into how we see them in imaging, to look into the different imaging modalities and understand their clinical value, to highlight commonly encountered cases in our local setting, and to review the techniques and some of the patient preparations in esophageal imaging. As we all know, the esophagus measures approximately 25 centimeters long from the nasopharynx down to the stomach. It is formed by 4 layers of tissue, namely the mucosa, the submucosa, the muscularis propria, and the adventitia. It characteristically lacks a serosal layer, which allows for the rapid spread of tumor to its surrounding structures. It is divided into 3 anatomic divisions with the following landmarks, namely the cervical, the thoracic, and the abdominal esophagus. Now, there are several imaging modalities that are used in evaluating the esophagus. Let's start with the first one, the esophagogram. This is what we also know as the barium swallow. It is the initial imaging modality of choice for evaluating motility disorders, suspected perforation, and obstructive lesions, and also to check for post-surgical anastomotic leaks. It is a multiphasic examination wherein barium preparations are ingested orally and filmed via fluoroscopy. The first image, figure 1 or figure A, is a single contrast technique wherein barium is swallowed to distend and evaluate the lumen. Figure B is a double contrast technique wherein air is used, followed by barium to detail the mucosa. There are several maneuvers that we do to elicit reflux, such as Valsalva maneuver. Now let's look at this example. This is a patient who is about to swallow a bolus of barium. As you can see, it is white or radio-opaque. With swallowing, the esophagus is distended, and we can see the different characteristics of the esophagus. It is smooth and featureless, and most of its length is tubular. At this point, we can see that there are 3 normal extrinsic impressions on the esophagus. The distal portion of the esophagus is also saccular. These are the normal characteristics. And let's look at the distal 2 to 4 centimeters a little closer. We all know that this is what we call the lower esophageal sphincter, and there are a few characteristic findings that we have to point out. The first one is pointed by the white arrowhead, which is the A-ring, and it signifies the junction between the tubular part and the vestibular part of the esophagus. The structure pointed by the red arrowhead is the B-ring, which is a mucosal notch that on a double contrast study corresponds to the Z-line, which is a ragged line along the mucosa. These 2 structures represent the squamocolumnar junction, and for that reason, they are the radiographic markers of the gastroesophageal junction. The second imaging modality is endoscopic ultrasound. The incorporation of ultrasound with endoscopy began in 1980s, and within a few decades, endoscopic ultrasound has become part of the standard of care in esophageal disorders. This is because it has the capacity to determine the depth of lesion penetration into the esophageal wall. For this reason, it is the modality of choice for locoregional staging in esophageal CA. It has also the capacity to differentiate benign causes of compression versus identifying a true growth within the wall. And since images in endoscopic ultrasound are real-time, it's capable of guiding clinicians in locating and sampling potentially affected lymph nodes. Now, when findings in barium swallow or from barium swallow or endoscopy are equivocal and they need further evaluation, cross-sectional imaging comes into play, and the first imaging modality is CT scan or computer tomography scan. It has the major advantage of demonstrating the extent of esophageal wall involvement and assessing the surrounding structures as well as regional lymph nodes. Let me show you the esophagus with the use of CT scan. This is a diagrammatic representation of a sagittal section of a person along the plane of the esophagus, and this is the CT correlate. As you can see, the esophagus is a tubular structure that lies along the posterior mediastinum with several pockets of air. As I said a while ago, there are three structures that cause normal extrinsic impressions on the esophagus, namely the aortic arch, the left mainstem bronchus, and the left atrium. Now this one is an axial section of a plain CT scan of the chest. Please remember that the top side of the screen is the anterior portion of the patient, and the right side of the screen corresponds to the right side of the patient. The esophagus on cross-sectional imaging appears as an ovoid soft tissue that is bordered by the trachea anteriorly and the vertebral body posteriorly. At this level, we can also see the thyroid gland. And in this patient, we can see here an indwelling internal jugular vein catheter inserted on the left. As we proceed inferiorly or caudally, most of the esophagus does not contain air, but when air is present, we have to remember that the normal air column should not be more than 1 centimeter, and that the presence of an air fluid level is always abnormal. As the esophagus enters the thoracic cavity, we see here 3 structures that correspond to the major branches of the aortic arch. And at this level, we see the aortic arch flanking the esophagus on its left anterolateral surface. Further down, we can see the trachea changing its configuration as it branches out to the 2 mainstem bronchi. And at this level, the esophagus is bordered by the left mainstem bronchus anteriorly, by the descending aorta on the left, and by the esophagus vein on the right. The left atrium abutting the anterior surface of the esophagus. As it enters the abdominal cavity, the esophagus assumes a more anterior position relative to the aorta, and it enters the abdominal cavity at the level of T10. The next imaging modality is positron emission tomography, or PET scan. As a quick review, PET scan involves the introduction of a radioisotope into the body, and this radioisotope is taken up by tumor cells. Once inside the tumor cells, it is metabolized into a substrate that is inefficiently metabolized, and therefore it accumulates inside these cells. Such uptake is then detected by scintillators and rendered into an image. Now, PET alone is not sufficient because of its low spatial resolution. That is why CT scan is used in conjunction for the anatomic detail. Its main role is for initial staging of esophageal CA and for detection of metastases and recurrent malignancy. Now, as a rule, metastases from esophageal CA occur in unusual and unexpected locations, and they can be radiologically occult. Now, let's look at this example. What we see here is a large soft tissue mass pointed by the black arrowhead at the gastroesophageal junction. This is very characteristic of a locally advanced adenocarcinoma. And when images from PET are fused, we can see indeed that there is high uptake of FDG within the tumor. However, pointed by the white arrow, there is also a focus of uptake within the right liver lobe. And any unusual foci of FDG uptake should be regarded with suspicion and should prompt further evaluation to exclude metastatic disease. Now, there is a population of patients with adeno-CA that may benefit with neoadjuvant therapy in the form of radiotherapy. These patients may have post-treatment esophagitis and such finding may also show diffuse FDG uptake on follow-up CT scan or follow-up PET CT scan. For this reason, it is not sufficiently reliable for determining the response in the primary tumor. However, let's also remember that in 18 to 17% of patients who receive neoadjuvant therapy, interval metastases may occur. And for this reason, PET-CT scan is capable of detecting such metastases, especially when they are occult. Take this for example. We can see here at the level of the left supraspinatus muscle, there is no overt lesion on conventional imaging, but on PET scan, there is uptake. The last imaging modality is magnetic resonance imaging. It is known for its superiority in evaluating soft tissue and mediastinal structures. However, it is not routinely used in the evaluation of esophageal disorders. But with the advent of stronger magnets, faster acquisition time, and respiratory gating mechanisms, MRI is beginning to be used in the evaluation of esophageal disorders. For example, small studies have used oral water as oral contrast medium to display the lumen, as you can see in Figure A. Figure B and C are sagittal sections of the same patient, showing the esophagus with and without oral contrast. Now, the same technique has also been studied and used by several clinicians in depicting esophageal CA preoperatively. It has also been used, the same technique has also been used in predicting response after radiotherapy. Figure A shows a mass at the distal esophagus, and Figure B shows a lesser degree of thickening after radiotherapy in the same area. So there are also non-malignant uses of MRI, such as the use of MR angiography to demonstrate esophageal varices. And also, cine MRI can also demonstrate gastroesophageal reflux disease. Now, these are the different modalities that are used to evaluate the esophagus, and they have different advantages and disadvantages over the other. But I think what is important is that one imaging modality should be complemented by another, and that the imaging modality of choice to assess a particular disease entity highly depends on the diagnostic question in mind. Now let us shift gears and look at the different esophageal disorders with a case-based approach. For the purpose of conceptual organization, esophageal disorders can either be benign or malignant, and those benign entities can be further classified in how they manifest radiologically. They can be luminal disorders, they can be wall disorders, or they can be motility disorders. And for every category has specific disease entities that belong under it. Let's look at our first case. Our first case is an 85-year-old female with difficulty in swallowing. Now, this is the esophagogram of the patient. Take note that this esophagogram is not on loop, but I will repeat it for you. All right. So before we proceed, let me ask you one question. What do you think is the predominant imaging manifestation in this patient? Can we have the poll question, please? All right, can we have the answer? Okay, 48% said it's a motility disorder, and I agree with most of you. This is indeed a motility disorder. This is what we usually call presbyesophagus, which is a term described as a term to describe the generating motor function of the esophagus among elderly. It is characterized by non-propulsive contractions or tertiary waves that gives the esophagus a beaded appearance or in severe cases, a corkscrew appearance. Let's have our second case. Our second case is a 31-year-old female who had repeated episodes of vomiting. Now, the patient had a previous EGD before being referred to our institution, and in the report, it said that there was resistance of scope progression towards the gastric region. So a barium study was requested, which showed the following findings. Now, let's look at each image. Figure A shows a dilated esophagus with slow and smooth tapering at the distal region. There is egress of contrast into the stomach, but take note, it's just a small amount. Now, figure B is a cross-table lateral view, wherein we see here an air fluid level, which signifies stasis. Now, when the patient's table was raised to 45 degrees, we can see here that it didn't change much, and we can see an inverted bird's beak appearance. So these findings are very characteristic of achalasia. It is the absence of peristalsis with failure of the LES relaxation. As a review, primary achalasia can be achalasia can be primary or secondary. The case that I presented is primary achalasia, and secondary achalasia or pseudoachalasia can also occur, and it is characterized by obstruction of the distal esophagus from non-functional etiologies such as malignancy. Our third case is a 56-year-old male, a caretaker from Batangas who presented with black tarry stools last January 2020. Now remember, that time, Taal volcano also erupted, and it was found out in the history that the patient actually ingested water that was contaminated with volcanic ash. So an EGD was done to this patient, which showed the following findings, and this was signed out as severe esophagitis of the mid to distal region with gastritis and duodenitis. So after a month, the patient was referred to our institution for barium swallow. These were the images that we were able to acquire. So what do we see here? We see that at the mid-esophageal segment, there is mild dilatation with abrupt narrowing of the mid to distal region down to the gastroesophageal junction. And this is the lateral view. Now, a CT scan was requested for this patient, and here are the images. So what do we see here? There is irregular wall thickening of the mid to distal esophageal region down to the proximal stomach, and there are web-like stenosis on eggshell imaging. So this is a case of esophageal stricture secondary to caustic ingestion, and I think it is important to note that volcanic ash is composed of a lot of harmful substances, and when it is added with water, it is considered as a caustic substance. So as a quick review of the pathophysiology of what happens to the esophagus with caustic ingestion. So there is mucosal injury at the minute of ingestion, and with days and weeks that pass by, there are several changes that we can see here. And at the time of the third week to a few months, there will be scar retraction and stricture formation. So before we go to our fourth case, let me now go to my second poll question. Kindly look at these images and tell me, what do you see? What are those opacified structure? Or opacified, this opacified structure here? So can we have the poll question? All right, can we see the answers? Yes, and 42% answered large intestine. So we'll go back to this image after we look at the fourth case. Our fourth case is a 39-year-old female who accidentally ingested muriatic acid. So this is the barium swallow of the patient. Let me repeat that for you. Okay, so what do we see? I think by now you are confident to say that there is stricture formation from the mid to distal esophageal region, and there is little egress of contrast into the stomach. And so for patients with severe stricture formation from caustic ingestion, corrective surgery is done, especially when endoscopic therapy fails or is deemed harmful. And such surgical options include partial or total esophagectomy with gastric pull-up or preferably colonic interposition, hence our image a while ago. So the same patient came back to our institution for follow-up, and these were the images that we acquired. What we can see here, beautifully opacified by the barium, are the hostrations of the large intestines. So, and at the end, at the distal portion, we can see anastomosis with the gastric bubble. So colonic interposition is a procedure requiring 3 anastomoses, and studies have shown that this particular procedure is more stable in terms of its functional outcome and has lower incidence of stricture formation. Our last case is a 73-year-old male who was referred to us because of dysphagia and weight loss. So here's the barium study of the patient. Okay, let me repeat that one more time. So as you can see, the barium is not able to pass through the distal region and down to the stomach. And this persisted for approximately 10 minutes. And afterwards, there was slow egress of contrast into the stomach. But let's take a look at this portion here. There is abrupt narrowing with irregularity of the mucosa of the lumen. Now, a CT scan was requested for this patient, which showed wall thickening at the distal region down to the gastroesophageal junction and to the proximal part of the stomach. And these findings are very characteristic of esophageal carcinoma. So what else can we see in our CT scan? Pointed by the yellow arrows are hypodensities in the liver that is very suggestive of metastatic disease. Okay, we're almost at the end of this discussion, and I'd like to share some frequently asked questions from us radiologists, especially when a patient is about to undergo barium study. And so what better way to start this portion than to ask you with another poll question. So what do you think of this statement? Since barium swallow studies essentially involve drinking, fasting is no longer required. Is that true or is that false? Okay, I think the answer to that is pretty straightforward. Can we have the results, please? All right, so 86% said that this is false, and yes, fasting is required. We ask patients to fast for approximately 4 to 6 hours, and this is to prevent some small food particles to be stuck along the esophagus and be mistaken into pathologies. We also have asked them to avoid smoking or chewing gum to decrease the secretions in the oral cavity and pharynx. So because we want the barium to coat the mucosa of the pharynx of the oral cavity and the esophagus well. So we also encounter certain questions like, what if the patient has high suspicion of perforation or leaks? So in such cases, we advise the use of an isoosmolar water-soluble contrast first. And when we have proved that there's no perforation or there's no leak, a barium preparation follows. Now, what if a patient has high risk of aspiration? Then we also advise the use of an isoosmolar water-soluble agent. And in severe cases, contrast can be given using an NGT. Now, when barium leaks into the mediastinum, it can cause inflammatory reaction. And when it leaks into the pleural cavity, it can also cause pleural thickening. Now, when barium is aspirated, it may also cause reactive pneumonitis. And in severe cases, although very rare, it can cause acute respiratory distress syndrome. So we advocate the use of an isosmolar water-soluble agent in such cases. Okay, so in summary, knowledge of basic anatomy is essential to proper imaging evaluation. The imaging modality of choice highly depends on the diagnostic question in mind. Good clinical data with a multimodality imaging approach are key to proper diagnosis and adequate management. And proper patient orientation and preparation aids in good image acquisition. Thank you very much.
Okay. Thank you, Dr. Sibal. We will not have the... Okay. Am I on? Hello?
Yes, sir.
Yes, sir.
Okay. We will not have the Q&A at this point. We'd like to proceed first to the lecture for the next lecture of Dr. Cabreros, which is in the stomach. And then after that, we will have the open forum. So, okay, our next speaker is Margrette Zyra Cabreros, also a graduate of the University of Santo Tomas. She had her residency training in radiology at the University of Santo Tomas Hospital and a CT MRI fellowship at the NKTI. I believe Dr. Cabreros is still with NKTI. So let's listen to her talk on imaging of the stomach.
Thank you, Dr. Ismael. Good afternoon, everyone, to our colleagues from the Philippine Society of Gastroenterology and the Philippine College of Physicians, as well as to our colleagues from the Philippine Society of Abdominal Radiology and the Philippine College of Radiology. I will be giving the second lecture for this afternoon, and my topic is on imaging of the stomach. So this is the outline of my discussion. First, we will be discussing the normal, specifically the imaging anatomy and the techniques of examination of per modality, and the second part will be the abnormal. So first part, let us begin with X-ray. The position, size, and shape of the stomach vary considerably from one individual to another. It is usually a vertically oriented J-shaped structure, and the region of the gastroesophageal junction is termed the cardia. The part of the stomach lying above the cardia, which is filled with gas in the erect position, is the fundus. Now, an imaginary line transecting the stomach from the incisura angularis on the lesser curvature to the greater curvature opposite further divides the stomach into the body proximally and the antrum distally. The antrum is then bounded distally by the pylorus, which is the junction of the stomach with the duodenum, and the pyloric canal is a channel through the pylorus. The luminal surface of the stomach has characteristic mucosal folds or gastric rugae. These are more prominent in the proximal gastric body and fundus, running parallel to the long axis of the stomach and usually measuring between 3 to 5 millimeters in thickness, and are usually absent in the antrum. Multiple fine transverse folds have also been described in the gastric antrum. If present, they persist when the gastric antrum is distended or partially collapsed, and also during peristalsis. They were originally thought of no clinical significance, but studies show an association between these persistent transverse folds and gastritis. During double contrast barium examinations and with adequate distensions of the stomach, the cardia appears as a central fleck of barium with radiating folds known as the esophageal rosette, or as others call it, the cardiac rosette. Several of these folds course for a longer distance along the lesser curvature, and this appearance may mimic ulceration. The micromucosal pattern of the stomach consists of mosaic of tiny raised nodules with intervening grooves known as the array gastricae or array gastrica. They are seen most clearly in the antrum, and normal appearance varies from fine reticular pattern to a coarse nodular pattern. The hallmark of normal is the regularity of the pattern in all areas in which it is visualized. We now move to the techniques of examination. As endoscopy has become more commonplace and with the widespread use of cross-sectional imaging, utilization of conventional radiographic techniques such as plain radiography and fluoroscopy in the diagnosis of diseases of the stomach has continued to diminish. However, in some areas and circumstances, plain abdominal radiograph may be the first line of investigation in the acute setting. For example, in cases of gastric outlet obstruction, foreign body ingestion, or in an evaluation of radio-opaque tubes and lines. In a scout film of the abdomen, particularly in the upright projection, you may appreciate the gastric bubble as a radiolucent rounded or at times crescentic area, generally nestled under the left hemidiaphragm, representing gas in the fundus of the stomach. We now discuss the upper GI series. So the single contrast technique upper GI series is a complex examination requiring fluoroscopic evaluation, also abdominal compression, and the use of multiple techniques for examining not only the stomach, but the esophagus and the duodenum as well. This is to demonstrate the rugal folds, assess the pliability of the gastric wall, and detect focal areas of rigidity secondary to tumor or scarring. Mucosal relief technique entails using small amounts of barium to coat the mucosa without distending the bowel to demonstrate abnormalities like varices. In contrast, a double contrast technique uses high-density barium suspensions to coat the mucosa and ingestible effervescent granules to distend the stomach and duodenum. And it is optimal for the demonstration of subtle features of the mucosal surface. The major principles of performance include mucosal coating, distension, and projection. And just to show you here the difference between single and a double contrast, in a single contrast, we use this to assess the size, the shape, position, and the contour of the stomach, while in double contrast, you see here that the mucosal lining is well visualized. Now we move to the next imaging modality, ultrasound. We all know that the gut is a continuous hollow tube with 4 concentric layers. From the lumen outward, these layers are the mucosa, the submucosa, the muscularis propria, and the serosa or adventitia. Now these histologic layers correspond with the sonographic appearance and are referred to as the gut signature, where up to 5 layers may be visualized. These sonographic layers appear alternately echogenic and hypoechoic, but it is best remembered that the muscular components, specifically the muscularis mucosa and muscularis propria, constitute the hypoechoic layers on sonography. This is a transverse ultrasound image of the stomach in a 20-year-old patient, showing us the gut signature and the 5 different wall layers. The innermost echogenic layer represents the interface between the gut lumen and the mucosa. The adjacent hypoechoic layer represents the muscularis mucosa. The adjacent echogenic layer represents the submucosa, and the adjacent hypoechoic layer represents the muscularis propria, and the outermost region represents the serosa, the outermost echogenic region. Now this is a sagittal and cross-sectional views of the stomach showing the normal gastric rugae on ultrasound. Also take note that a collapsed stomach would show variable wall thickness. This is a stomach distended with 200 milliliters of water. the stomach wall appear obviously smooth when distended and takes on a cystic appearance. The anechoic content here is the water, and the small echogenic specks within the water are due to bubbles of air and are normal to see, and this will actually be mobile in real time. Next, we move to computed tomography scan. The stomach appearance depends on the degree of luminal distension and gastric location. For a well-distended gastric fundus and body, a wall thickness of up to 5 millimeters is considered normal. The mural thickness of the antrum, however, is affected by the anatomic and functional factors that make it normally thicker than the other portions of the stomach. And just to orient you in cross-sectional imaging, axial images, this would be the right side of the patient and the left side, anterior and posterior. And for the coronal, still, this will be the right side of the patient and the left side of the patient. In most patients, there is a layered enhancement of the normal gastric wall on contrast-enhanced CT. The mucosa brightly enhances, while the submucosa remains lower in attenuation. The muscular serosal layer has moderate enhancement. This is more commonly seen during the arterial phase, but can also be seen in a few patients during the portal venous phase. For the techniques of examination, scanning protocols should be optimized, particularly for staging of gastric cancer. Typically, around 1 liter of oral contrast material, preferably water, is given approximately 45 minutes before the study. And then an additional 250 to 500 ml should be given immediately before scanning in order to obtain optimal gastric distension. Important to note that luminal distension is imperative, as a collapsed gastric wall can produce pseudotumors or obscure pathology. Also, contrast mixing with food can produce pseudotumors. Therefore, it is preferable that the patient be fasting for at least 6 hours before the study. However, these protocols may vary in every institution. And also, positioning of the patient in the left lateral decubitus can improve distension of the antrum and cardia, while positioning the patient prone would improve fundal distension. Traditionally, high attenuation or positive contrast agents have been administered to enhance and distend the stomach and gastrointestinal tract. Although these agents are safe, well tolerated, and result in good gastric distension, they may not be optimal when evaluating the stomach. We prefer to use water as an oral contrast agent in patients with suspected gastric disease. It allows better evaluation of the enhancing gastric wall and may allow better detection of subtle disease. Water is inexpensive, usually free, and it is well tolerated. It distends the stomach well and does not interfere with the manipulation of the 3D datasets. Now we move to magnetic resonance imaging. On MRI, 2 to 3 layers with different signal intensities in the normal gastric wall can be depicted. The inner layer, or the mucosa, would show an increase of signal intensity on T1 weighted image, while the second layer, submucosa, would be hypointense. The outer layer, the muscularis propria and the serosal layer, would show a hyperintense appearance. And on T2 weighted image, it would present as the opposite. Now, for MRI, the patient preparation is almost the same with CT scan, also with the same principles. It is important to empty the stomach to avoid misdiagnosis of pseudotumors or masked subtle irregularities. Also, antiperistaltic agents are used to decrease motion artifacts. And for a more adequate distension, some studies even suggest using effervescent granules. Use of breath hold sequences will also be employed, and these are to minimize respiratory motion artifacts. So far we have discussed the different imaging modalities, the imaging anatomy and techniques of examination. And as with any radiographic exam, attention to detail and tailoring the examination to address the clinical problem is essential in producing optimal results. There will be protocols for every modality, but it is important that the radiologist knows what the clinician is looking for so as to tailor the examination and be able to adjust accordingly and come up with a good evaluation and diagnosis. Okay, so I know it is almost dinner time. Maybe you're hungry, but we have to continue with our discussion. We now move to the second part, the pathologies. And due to time constraint, we will not be able to discuss all the pathologic conditions of the stomach. Hence, we will only be discussing some of them. And I have grouped it based in its presentation as filling defects or mass lesions, folds or wall thickening, and lastly, a brief discussion on gastric ulcers. For the gastric filling defects or mass lesions, we will discuss carcinoma, lymphoma, GIST, metastasis, and polyps. But first, it's time for some interactive activity, our poll question. For our poll question number 1, which of the following is not a common morphologic growth pattern of gastric CA? Is it polypoid, exophytic, infiltrating, or ulcerative? Again, which of the following is not a common morphologic growth pattern of gastric CA? Is it polypoid, exophytic, infiltrating, or ulcerative? Okay, so time is up. Let us now look at your answers. And most of you answered polypoid, which actually is wrong. The correct answer is exophytic. So in gastric carcinoma, the tumor assumes 4 common morphologic growth patterns. 1/3 actually are polypoid masses that present as filling defects within the gastric lumen. Here is a double contrast study of a polypoid mass on the greater curvature of the gastric body. Despite its size, this lesion was found to be an early gastric cancer. And sometimes, even on plain abdominal radiographs, mass lesions, especially the large ones, are evident. Here is a close-up view from an abdominal radiograph showing us a soft tissue mass indenting on the lesser curvature of the gas-filled stomach. And this was proven to be a polypoid gastric carcinoma. Another 1/3 are ulcerative masses presenting as malignant gastric ulcers, and later on we will discuss malignant ulcers further. The remaining are infiltrating tumors. They are either fungating or focal plaque-like lesions with central ulcer, or diffusely infiltrating, producing bizarre thickened folds and thickened rigid stomach wall, the so-called serous carcinomas. Now here is an image, HLCT, demonstrating a nodular thickening of the antrum of the stomach caused by poorly differentiated gastric carcinoma. The outer margins of the stomach is well defined, giving evidence against extension of tumor through the wall. Also note the fixed narrowing of the gastric lumen. Now here are images from serous carcinoma cases. This is a single contrast and this is a double contrast in another patient showing a nodular and irregular mucosa in the fixed and narrowed distal stomach. Here are images from 4 different patients showing the various CT appearances of gastric carcinoma. This is the polypoid neoplasm. Image B shows us the fungating type. And also note here in this patient the presence of multiple hepatic metastasis. In image C, this is the ulcerated neoplasm, and image D is the infiltrating neoplasm. Now, this is a case of a false positive CT for gastric carcinoma. Here in image A is an axial CT scan showing a focal area of apparent wall thickening in the gastric body that is worrisome for an infiltrating tumor. And on image B, a frontal view of the stomach from a subsequent double contrast upper GI series shows a normal appearing stomach without any findings to suggest tumor in the gastric body. And in patients with suspected gastric cancer, the accuracy of CT scan can be improved by using appropriate techniques, as what we have discussed a while ago, to ensure that the stomach is maximally distended. Another example illustrating the importance of distension of the stomach for determining extent of gastric carcinoma. This is a 58-year-old patient with abdominal pain who underwent for routine CT. Image A and B are the ones showing us the routine CT scan, showing the thickening of the stomach wall. and an endoscopic biopsy for this patient confirmed an adenocarcinoma. Now, image C and D are the subsequent staging CT, showing us the actual extent of the tumor to be at the gastric body, and it shows us that the gastric fundus is free of the tumor. And this was not apparent on the initial CT due to the collapsed normal gastric mucosa in an undistended stomach. Here are multiplanar images from a CT, A to C images, and D to F images are MRI. These are T1 weighted contrast enhanced images. There is an ulcerated mass along the lesser curve of the stomach with superficial enhancement. Note that there is no surrounding fat stranding or lymph nodes. The involved gastric wall is also in close approximation to the left lobe of the liver here. And better demonstrated here on the sagittal T1 weighted MR image is a fat plane in between the stomach and the liver. CT is considered the imaging modality of choice for staging of gastric carcinoma with its ability for non-invasive assessment of local extension of tumor, nodal disease, and also of metastasis. And MRI provides better soft tissue contrast than CT, but due to its long acquisition time and susceptibility to motion artifacts, CT is more often done. Now here is an MRI of a 71-year-old female patient with gastric cancer. This is a coronal image showing the enhancing wall thickening at the gastric body. On T2 weighted image, it delineates a hypointense mass destroying the layers of the gastric wall. And on DWI, it showed evidence of restricted diffusion. And on subtotal gastrectomy, pathological examination revealed a T3 cancer for this patient. Now, PET-CT, or PET combined with CT, has been recognized as a useful diagnostic technique in clinical oncology. And PET has a low sensitivity for the primary tumor, therefore it is limited in the preoperative workup and best used as part of a comprehensive workup and therapeutic monitoring as well. In this image, this is an axial CT demonstrating lymph nodes adjacent to the left gastric artery and the common hepatic artery. And the diagnosis of lymph node metastasis may be difficult if only size criteria are used. On axial PET scan, it shows prominent FDG uptake in the corresponding lymph nodes, and these findings suggests metastasis. Lymph node metastasis was also proven on pathology. Now here is a case of a hepatic metastasis in a 54-year-old patient with gastric CA. Here is a portal venous scan showing the 4 metastatic nodules, none of which is easily discernible. But on axial PET scans, it clearly depicts these nodules. Now we move to the next pathology, the gastric lymphoma. The stomach is the most common site of involvement of primary GI lymphoma, and it also demonstrates 4 morphologic growth patterns: the polypoid, ulcerative, multiple submucosal nodules, and diffuse infiltration. Rarely, linitis plastica appearance of diffuse stiff narrowing can also be seen in lymphoma. Now here is a CT scan showing us the marked thickening of the gastric wall with homogeneous enhancement caused by the infiltrative form of gastric lymphoma. And on this image, the ulcerated gastric lymphoma showing the large ulcer crater present within a soft tissue mass in the stomach. If you've noticed, there is an overlap of the characteristics of gastric carcinoma with lymphoma, and CT findings that are helpful in determining or differentiating gastric lymphoma from carcinoma would include: in lymphoma, there is a more marked wall thickening, may exceed 3 centimeters. Also in lymphoma, there is absence of luminal narrowing and obstruction despite its extensive involvement. And in lymphoma, there is more widespread and bulkier adenopathy. Now we move to GISTs. Long-term silent growth to a large size is characteristic, and the overlying mucosa is commonly ulcerated. Dystrophic calcifications is relatively common in both benign and malignant tumors, and it would help differentiate these lesions from other gastric tumors. On upper GI series, GISTs appear as submucosal nodules and masses. Now here are CT images showing us pictures of malignant cysts. Now CT is useful in characterizing the tumors because they are predominantly extraluminal. Benign tumors basically are smaller, they're homogeneous, and would show uniform enhancement, while malignant tumors would tend to be larger and show irregular patterns of enhancement. Now in this image, this is a large heterogeneous exogastric mass seen arising from the posterior wall of the stomach. In another patient, there is here a heterogeneous exogastric mass seen insinuating between the stomach and the pancreas. And in a third patient, a gas and fluid-filled mass projects posteriorly from the stomach, and although uncommon, this degree of necrosis can occur with malignant cysts. And this is a coronal scan showing a large mass arising from the lesser curvature of the stomach. Note the wall of the lesion is irregularly thickened. Metastasis may present as submucosal nodules or ulcerated masses. The common primary tumors are melanoma, breast, and lung carcinoma. Now here is an image of a metastasis from malignant melanoma producing innumerable polypoid nodules protruding into the stomach. Also, other primary are also documented. Here is an image of a round calcified metastatic mass from an ovarian cancer in the antrum. And here on this image is a coronal image showing gastric metastasis from, this time from an esophageal carcinoma. Note that in this patient, it is in a submucosal location. And on this image is a coronal scan with a metastasis from a cholangiocarcinoma. Note this two subserosal metastases to the stomach, and all of these were pathologically proven to be metastatic from their primary. Now, polyps are lesions that protrude into the lumen as sessile or pedunculated. A polyp on the dependent surface may appear as radiolucent filling defect in the barium pool, and on a polyp on the non-dependent surface is covered with a thin coat of barium. Okay, so time for another poll question. What sign is depicted in this image? Is it the Mexican hat sign, the corkscrew sign, the wriggler sign, or the bowler hat sign? Again, what sign is depicted in this image? Mexican hat, corkscrew, wriggler, or the bowler hat sign? Okay, so time is up. Let us now look at your answers. And 50% answered the bowler hat sign, and that is actually the correct answer. The bowler hat sign is produced by the acute angle of the attachment of the polyp to the mucosa. This sign can also be seen in colonic diverticulosis, and it appears when the X-ray beam catches its margin in tangent, resulting in a lesion whose margins are etched in contrast. The Mexican hat sign consists of two concentric rings and is produced by visualizing a pedunculated polyp seen on end. And the outer ring is formed by the barium coating the surface of the head of the pedunculated polyp, and the inner ring would represent a meniscus of barium surrounding the stalk of the polyp. Hyperplastic polyps account for 80% of gastric polyps. They are not neoplasms, but rather hyperplastic responses to mucosal injury, especially gastritis. Adenomatous polyps are true neoplasms with malignant potential. Most are solitary and are located in the antrum. Now, for the next pathology, the thickened gastric folds and thickened wall, we have gastritis and neoplasm. Gastritis is a convenient label used to describe a wide variety of disease affecting the gastric mucosa. Most of these diseases are inflammatory. The hallmarks of gastritis are thickened folds and superficial mucosal ulcerations or erosions. Now, erosions are defined as defects in the mucosa that do not penetrate beyond the muscularis mucosa. Aphthous ulcers are complete erosions that appear as tiny flecks of barium surrounded by a radiolucent halo of edema. Again, it's time for our poll question number 3. Which type of gastritis is shown in this image? Is it atrophic, H. pylori, erosive, or phlegmonous gastritis? Again, which type of gastritis is shown in this image? Atrophic, H. pylori, erosive, or phlegmonous? And let us now look at your answers. And majority answered atrophic, and that is correct. But first, let us discuss H. pylori gastritis. This is the most common form and is the most common cause of thickened gastric folds. Upper GI findings of H. pylori gastritis would include thickening of the gastric folds, also presence of erosions, inflammatory polyps, and enlarged area gastrica. Now, erosive gastritis is most often caused by alcohol, aspirin, and other NSAIDs or steroids. Double contrast upper GI findings would include erosions, such as aphthous ulcers shown in this image, but others may also present with varioliform. Now, here is an image of multiple varioliform erosions seen in the antrum as tiny barium collections with surrounding halos of edematous mucosa. And here in this image is an image of an erosive gastritis with incomplete erosions. Now, atrophic gastritis is a chronic autoimmune disease that destroys the fundic mucosa. And it usually spares the antrum. Destruction of the parietal cells results in decreased acid and intrinsic factor production, and it would lead to vitamin B12 deficiency and pernicious anemia. Characteristic upper GI findings are decreased or absent folds in the fundus, and also narrowed tube-shaped stomach and a small or absent area gastrica. Now, here's an image of gastritis on CT. This is an oblique coronal image showing the marked thickening of the antrum in a pattern that is difficult to distinguish from a carcinoma. Note the enhancing mucosal lining and irregular folds. And endoscopy did not demonstrate an ulcer for this patient, and multiple biopsy specimens demonstrated only acute gastritis. And here on this image is an axial CT scan showing gastritis of the antrum as focal thickening and enhancement of the wall. Note also the preserved mucosal lining. And biopsy demonstrated H. pylori-induced gastritis for this patient. Now, neoplasms may also present with thickened gastric folds and thickened walls, specifically lymphoma and superficial gastric carcinoma, and these are already discussed earlier. Now we move to the last pathology, the gastric ulcers. An ulcer is defined as full thickness defect in the mucosa. It frequently extends to the deeper layers of the stomach, including the submucosa and muscularis propria. Most of them, 95%, are benign, and listed here are the signs of benignancy of a gastric ulcer. The hallmark of benign ulcers and the basis for most radiographic signs of benignancy is mucosa that is intact to the very edge of an undermining ulcer crater. Now, here is an image of a large ulcer with multiple folds seen radiating into the edge of the ulcer crater. And on this image, a smooth round ulcer seen projecting beyond the lesser curvature. The radiating folds and enlarged area gastrica in the adjacent mucosa are caused by surrounding edema and inflammation. And this is an image in another patient showing a lesser curvature ulcer. And note here the radiolucent band of edema or ulcer color adjacent to the ulcer. And this is what we call the Hampton line. And lastly, malignant ulcers. Malignant ulcers demonstrate signs that are the antithesis of benign ulcers. Evidence of irregular tumor mass or infiltration of the surrounding mucosa is evidence of malignancy. And in this image shows us the Karman meniscus sign. There is a large, flat, malignant ulcer that traps the barium within its rounded edges and seen as a band of lucency surrounded surrounding the barium collection. And here are representative images. Here in this patient, an irregular ulcer on the posterior wall of the antrum with scalloped borders and nodular clubbed folds surrounding the ulcer. These are classic features of malignant gastric ulcers. And this patient has an ulcerated mass on the greater curvature of the antrum. Note how the ulcer projects inside the gastric lumen with a discrete tumor mass etched in white here. And I think that would be my last slide. So for this afternoon, we have discussed the imaging anatomy and the techniques of the different modalities, as well as some disease entities and their radiologic appearances as gastric filling defects or mass lesions, thickened folds and thickened wall, and gastric ulcers. And with that, I would like to thank you for your attention.
Okay, thank you very much, Dr. Cabreros. Before we move on to the question and answer, I just would like to emphasize what Dr. Cabreros have mentioned earlier, that as clinicians, we should be coordinating with our radiologists as to what we are looking for, so that they will tailor the examination and they will examine the area that we are interested in much better. So I think that should be really emphasized to our fellows in training, that we need to coordinate with our radiologists whenever we request for any imaging of the gastrointestinal tract. So there are actually 3 questions already. And I think the first question is directed towards Dr. Sibal. He is asking if you can confidently say that the air fluid level in the distal esophagus on CT is hiatal hernia versus gastroesophageal reflux.
Yes, actually, even with just plain radiograph, the presence of an air fluid level in the area of the retrocardiac area is highly suggestive of hiatal hernia. And on CT scan, other than an air fluid level in the distal esophagus, we also look for secondary signs, such as the presence of fat surrounding the distal esophagus, and also the widening of the esophageal hiatus is suggestive of hernia instead of gastroesophageal reflux.
Or do you do some maneuver to elicit for a reflux?
Yes, we ask patients to perform Valsalva maneuver in certain cases, and we also sometimes ask them to raise, we actually raise the lower extremities to increase the intra-abdominal pressure.
Okay, here's another question from Dr. Payawal. What is the best imaging for the diagnosis of Guilfoyle lesion? Anybody can answer that? Dr. Cabreros or Dr. Sibal?
Yeah, actually, so Guilfoyle lesions are, I believe, dilated tortuous vessels. They are submucosal arteries that cause significant bleeding, upper GI bleeding. And since these are dilated vessels, I think the best imaging modality would be a CT angiography or a CT angiogram. So on CTA, these lesions appear as linear or serpentine foci or lesions within the submucosal area. And sometimes in cases of active bleeding, there is extravasation of contrast into the lumen. So this is, these are the things that we look for if we're looking for that lesion.
Okay, of course, Guilfoyle lesion is quite difficult to diagnose, even during endoscopy. If it's not actively bleeding, you may not be able to see it. Now, there's a question from Dr. Manli Uy. Can we use effervescent tablets with water as negative oral contrast for CT scan? Or perhaps Dr. Cabreros can answer this. Instead of just plain water, you add a effervescent tablet. And before you answer that, Dr. Cabreros, are effervescent tablets still available? When I was a resident, that was a long, long time ago. It's called GastroLoof because we do a lot of upper GI series at that time. So are effervescent tablets available?
There are still some effervescent tablets that come with some barium preparations or contrast preparations, but they are actually seldom used now, especially for CT scan, especially also that the water alone itself would already give a good distension of the stomach, would be adequate for proper evaluation of the stomach lumen.
Okay, any other questions from the audience? I see some hands being raised. Dr. Jose Rizal Lubag, would you like to turn on the mic of Dr. Lubag? Dr. Lubag, you have to unmute your laptop.
I wasn't asking any question. There was no question.
Can you speak louder?
I wasn't asking any question. I don't know why. I was called.
Okay. Okay. So it was a mistake that you raise your hands. Okay.
Okay. Sorry about it.
Okay. So how about the use of upper GI series after doing CT? You mentioned it in your example, Dr. Cabreros. This is a question coming from from your teacher, Dr. Estrelita Ruiz, Hudan Ruiz.
Yes, doctor. For like the one I have given example a while ago, that patient had CT scan, but during that time the stomach was not distended, so there was a suspicious gastric wall pathology, suspicious for a malignancy. But on the subsequent upper GI series that was done in a double contrast technique, there was a better evaluation of the gastric wall, and there was it actually revealed normal findings for that patient. So I think if in patients wherein you would not want to repeat the CT scan again, and you would want to have a specific pathology to be determined that can be evaluated by upper GI series, maybe yes, it can still be performed.
Dr. Leisa Pilar, have a question. I had a patient who had an upper abdominal ultrasound, and part of the official reading was gastric hyperacidity. Is this possible to read this part of the stomach through ultrasound? Hyperacidity in ultrasound.
I have not encountered hyperacidity on ultrasound. Maybe we can ask my mentors if they have any also, if they have encountered.
Okay, how about Dr. Fragante is raising her hand. Can you unmute the mic of Dr. Fragante?
We have not given a diagnosis of hyperacidity, so maybe we should ask the radiologist who did that examination, because we have not given a diagnosis that way. I don't think it's possible to be able to do it by ultrasound.
I probably will not pay too much attention if that is the diagnosis. No? I believe that one cannot make a diagnosis of hyperacidity by doing ultrasound or upper GI series or even endoscopy. Okay, when we say hyperacidity, that means you need to do some gastric acid studies. Well, there are lesions that may be associated with gastric acid overproduction, like peptic ulcer disease in Solinger-Ellison syndrome. No, but by itself, we shy away from making that diagnosis or even telling the patient that you have hyperacidity, because that's what commonly what we hear from patients who have been consulting other physicians. Meron daw akong hyperacidity, doctor. So that's probably not true. There's another hand that's being raised, Dr. Big Ang. Can you unmute the mic of Dr. Ang?
Oh, hear me?
Okay, go ahead, Dr. Ang.
Yeah. Well, we are endoscopies, so maybe we are biased. So in any way, if we see a suspicious lesion in any of the imaging modality, I guess endoscopy would be more, I should say more preferred procedure, considering that it can allow biopsies to be taken, and this would really help in the assessment of the patient rather than do another imaging. Okay.
You are probably referring, Dr. Ang, to that question of Dr. Ruiz earlier, where there was an abnormal CT scan and an upper GI series was done. So you would prefer, as a clinician, you would prefer to do an upper GI endoscopy rather than an upper GI series, if the CT scan showed some abnormal findings.
Yeah.
Am I right, Dr. Ang?
A follow-up to Dr. Hudan's question.
Okay. So I was told that we maybe 2 or 3 more questions. From Dr. Balse Santos, some hospitals without fluoroscopy do modified esophagogram. Is this as accurate as esophagogram with fluoroscopy? Dr. Sibal?
Yes. As far as I know, the modified esophagogram is actually a variation of the traditional esophagogram. But the indication for such is usually for looking for potential aspiration or evaluation of oropharyngeal dysphagia. If I think it very highly depends on what we are looking for. Yeah.
The problem for these cases in which you do not have a fluoroscopy, you could not evaluate the motility along the esophagus. That is the problem. So you could see the morphology, but not the motility of the esophagus. And you could not be able to demonstrate reflux.
Okay, thank you, Dr. Fragante. Last question from anonymous attendee. Great and well-detailed lecture. What are your alternatives for those patients who can't tolerate the 1 liter contrast or water that will be given prior to CT scan of the stomach?
Actually, the 1 liter volume of oral contrast is for the distension of the small intestinal segments. For the distension of the stomach, around approximately 250 ml would be enough. And as I've mentioned, this would be the one given immediately before the scanning time, so that this would still be in the region of the stomach upon scanning of the patient. So I think the 1 liter, if the patient cannot tolerate it, and if we are looking for a stomach pathology, it would be okay if the patient would have around 250 or 300 ml right before the scanning.
Before you go, there's another question, Dr. Cabreros, about the number of films for an upper GI series. How many should you take? Number of films in upper GI series.
This would actually depend on every institution and every protocols, and also would depend on every pathology that will that is being evaluated.
Ang problema kasi nagtitipid. So pwede na ba yung 5 or 6 films daw?
Actually, the problem here really is how efficient or how well you're able to get the different views. For example, the duodenal bulb, you have to get it in full. So some are very good in getting it. You could get it in 2-in-1, but it really depends. Usually you use around 6 to 8 films in a normal upper GI series.
Okay. Thank you, Dr. Pragante. I think that should be the last question. I will now give you back Dr. Romel Romana. Thank you, Dr. Cabreros and Dr. Cabreros and Dr. Sibal for those excellent lectures. Dr. Romana?
Yes, thank you very much, Dr. Sibal and Dr. Cabreros. And thank you, Dr. Ismael, for complementing the discussion this afternoon. All right, so this actually is the conclusion of our 4-part lecture series on GI radiology. On behalf of the Philippine Society of Gastroenterology and the PSG Committee on Training Program, I would like to express my utmost appreciation to the Philippine Society of Abdominal Radiology and to Dr. Silva, the president of the society, for accepting our invitation to conduct this lecture series for the fellows and actually for the members of our society. It has been a very educational 4 weeks. The reception has been overwhelming and the attendance is excellent. We look forward to collaborating with your society again for similar endeavors in the future. And again, thank you very much. Okay, so before you leave this one, or well, actually after you click on the leave button for this session, please do not forget to answer the short survey that will be shown after you click the leave button. And while this this is the last of the radiology series, the webinar series actually does not end here. And next week, we shift gears to discuss the first of 2 GI pathology webinars. The first topic next week, same time, 5 o'clock, would be the pathology of the esophagus, stomach, small and large bowel by Dr. Glendalyn Pua and moderated by Dr. Cesoliano. Okay, so see you again next week. Thank you for attending and good evening, everyone.